Hi everyone, welcome to this information session about the Primary Care Improvement Collaborative. Thank you for joining us today. This is just a short session. We'll be sharing some information and hopefully answering a lot of your questions about how the collaborative is going to work. I'm Alison Serran. I'm a Senior Improvement Advisor in the Primary Care team in Healthcare Improvement Scotland, and I've been leading the development of the collaborative so far, and with a couple of my colleagues, I'm going to take you through a bit of information today. Just to start out, a little bit of housekeeping. So because we have a few people on the call today, we've switched cameras and microphones off, except for presenters. So we really encourage you to use the chat function if there's anything that you'd like to share or anything that you'd like to ask particularly. So at the end of the session, we'll be trying to pick up some of the questions from the chat, as well as some of the ones submitted ahead of the session. If we get loads of questions and we can't quite answer them all, then we're really committed to answering those for you. So that's most likely going to be part of an FAQ document that we'll circulate to everyone who's attended after the call, and to everyone who's registered. So the session is being recorded. The recording has started, and it will be available on our web pages afterwards. So if you have any colleagues who weren't able to join, or anyone else who you think might be interested, then feel free to direct them to the recording, and we will let you know when that recording is available for you to have a look at. Just to get us started, it would be really helpful for us to know a little bit about who's attending the session today. So there should be a couple of polls that are going to pop up for you just now to fill in. The first one, so these are, we won't be recording your name and your details, but so the first question is just which service do you work in? So whether that's a general practice or other areas of primary care, or whether you're not in a clinical role at the moment, if you could just pop your answers in there. And then once you've done that, should be a little button in the bottom right-hand corner where you can click through to the next poll, where we're just asking you to tell us where in the country you are. So which board or which HSCP you're based in, and just to get a bit of information about who's able to join us today. Great, thank you. Feel free to continue to populate those. So, as you probably are aware, or most people are probably aware, the Primary Care Improvement Collaborative is part of our Primary Care Phased Investment Programme, which is a bit of a bigger programme. And the collaborative part is the part that is open to all primary care teams across Scotland who are not participating in the demonstrator sites part of the programme. So we have 4 demonstrator sites that we're working with, and those are the only people who are not invited to join the collaborative. And that's not because we don't care, it's because we're already giving really focused improvement support to those areas, and we'll be working with you anyway. So if you're in one of those areas, come and talk to us if you'd like to, or speak to the leads in your HSCP. We'll talk a bit more about the criteria later in this session, because that is a bit different for some of the different sites. But for everybody else, the collaborative is open for you to join, and it's the best way really to understand what's happening in the programme, to stay in touch, to hear the updates, and to share the learning, both from what we do together and from what's happening in those demonstrator sites. If you're not sure, do reach out and talk to us. We're happy to have a conversation about what's the best way for you to be involved in the overall programme. This slide's just showing then the aims of the programme, and these are the overall aims for the programme. So we want to be developing a culture of continuous improvement. So we want to make sure that people are working quality improvement work, and able to do that without help from Healthcare Improvement Scotland as well. And to build on those skills that we know so many of you have already got. We're looking to improve the implementation of particularly those services from MOU2, so pharmacotherapy and community treatment and care services, but whilst maintaining the other really important MDT services in primary care. And we want to build a bit of evidence to understand the national context for implementation of the contract, and that's really to inform our colleagues in Scottish Government and for them to be able to make future decisions about investment in primary care. So those are the overall aims of the programme. In the collaborative, the way that we'll do that is by building some quality improvement skills, and then working on some fairly small scale tests of change. So testing changes to processes and to the things you do in your day-to-day roles, and then sharing our learning. So the learning that we've got from doing that work, from previous work you might have done, and also sharing the learning from what's happening in those demonstrator site teams. So I'm just going to give you an overview of how we think the collaborative might look. And I think this is really key because this is a bit of a different type of collaborative from if you've worked with Healthcare Improvement Scotland before in a collaborative, you might have an idea of how that would work. And some of the elements will be the same and some things will be a bit different. So to give you a bit of an overview, this is an example program for the first year of the collaborative. And it's an example because what we really want is to be able to adapt the program in response to what you're looking for. So anything you can tell us. And if you do go on to apply, we will be asking a few questions about which bits you're interested in and what you want to work on. Anything you can tell us about what you'd like to do will be really helpful in helping shape what the program looks like. But this is our current plan. And to just take you through it, the length of the program would be until towards the end of 2025. So we've just mapped out the first year. But for that first year, the top row that's in purple are activities that cut across both sides of the program. So some of it's shared between the collaborative and demonstrator sites. And those are primarily some shared learning sessions where we'll bring everybody together to talk about what we're learning, the insights, any of those real sparks of an idea that can make a big difference that everybody might want to know about and go away and work on. And then some monthly quality improvement skills sessions. So for some people, that will be a bit of a refresher or a way of applying something you've used before to work in the setting you're in now. And for other people, that might be a first experience of learning a bit about quality improvement, the way that we work, and why that's a useful tool for us when we're trying to improve services for patients. And so those things will be open to everybody. And then the remaining 3 rows, we've kind of split in this diagram down into 3 work streams. And the top blue one is the primary care access program. This is a program we've been running for the last year or so. And it works with any kind of primary care team. So this is open to anyone. And it's primarily looking at things that can improve access to your service. So that can be a range of things. It can be how appointment systems work. It can be looking at the kind of queries and phone calls you're getting. But it can be things that we haven't even tried before as well. So there's a lot of range there in what we can work on and who we can work with. The second row is pharmacotherapy. So that's both pharmacotherapy and pharmacy teams, but also practices who want to work with pharmacy colleagues on a project. And then the bottom one is community treatment and care services. And again, primarily those services, but also practices who want to work on that and improve perhaps the way that people are referred on to those services. And on each of those tracks, you see there's a mixture of different things. So there are some 8-week and 4-week sprints where we will work with a selection of teams, so not the whole collaborative, but a few people who have told us that's what they want to do and who've been offered a spot, would work with one of our improvement team over a focused period of time to test a change. So to have a think about what do we know about our current system, and what might make a difference, and then to test that out together. And we'll come on to what the commitment looks like for doing those different activities. But for each stream, there's 8-week sprints, there are 4-week sprints. 4-week sprints we think would focus on a very specific topic. So we've tested this previously with acute prescriptions, things where we have got a bit of evidence on what works and we know a pathway through for people, and you just need a bit of help to get started. And then for each of those, there'd also be a monthly support and learning session, and these are open to anyone. So it can be teams who've completed a sprint, it can be teams who haven't, and you can drop in and out of those as you'd want to. Really importantly, all of these activities are optional, so teams can participate as much or as little as you would like to. For sprints, we will say these are the teams who are on this sprint, but you could always come back and do another one, or you could do one later in the year. But all the activities are optional. There's nothing that is a requirement for you to attend to be part of the collaborative. And teams are really welcome to choose to fit with your capacity and what you're interested in. There's also no need to pick one of these work streams and stick with it. So if you want to do a bit of work on access first, that doesn't mean you can't come back and do a bit of work on a pharmacy project at some point in the future. So we thought it might be helpful to just talk you through a couple of examples of how that might work, because I'm aware it can be a bit complicated. So if we think about a GP practice, so a GP practice you might join and think, we're not quite sure actually right now whether we've got capacity to work on a sprint and commit a few hours a week to doing that. And so it would be really possible to start attending those support and learning sessions, to start hearing about what other people are working on, and then think a bit later in the program, actually, are we ready now to do a 4-week sprint? Or are we thinking about something that involves our pharmacy team or our CTAC team, and we'd like to do some work with them in one of those sprints? We've had a couple of inquiries about other kinds of MDTs. So this is really open to all primary care teams. So you might be a team of AHPs or physio team or something like that. Those teams are really welcome to join that. Particularly the access sprints probably be where there's the most value, but any of the activities, and then attend any of the other sessions as well. I know I've also spoken to a few of our teams who've completed work with us before. So, for example, there might be some pharmacotherapy teams who've worked with us earlier, just towards the end of last year. And those teams might want to join and actually really don't want to do any more focused improvement work in a sprint just now, but it might be that it's really helpful to attend the support and learning sessions and to continue to update on progress, to get a bit of advice, to hear what other people are working on, and to attend those shared learning sessions in the top row as well, to hear about what's happening in the demonstrator site teams as well. So I hope that helps a little bit to give you some context of how things might work in the collaborative. Just a few kind of key points. So I think most importantly, you can participate as much or as little as you like. We'll be trying to share learning across the whole programme, and it's open to all primary care teams except those who are going to be part of one of the demonstrator sites. There's no need just now to decide exactly what you want to do. So what I would really encourage you to do is, if you're interested, put in an application. The application form is open. It will take 4 or 5 minutes to complete. And then what we'll be doing after that is being in touch to discuss with you what you'd be interested in doing. And so you can indicate as many things as you'd like to do, but there's no commitment by filling in that form that you're definitely going to do a sprint or you're definitely going to do it at a particular time. We'll always be coming back to have a conversation about it first. So I'm going to pass over to my colleague Claire, who's going to tell you a bit about a few examples of things people have worked on, particularly in those sprints with us before. Thanks, Claire.
Thanks, Alison. Hi, I'm Claire Dawson. I'm one of the improvement advisors working in the primary care team and going to be working with you guys in the collaborative. So if we're looking at these examples here, these are things that people have done in our PCAP programme already. One of them is an example from a general practice team, one's an example from a pharmacy team, and one is an example from a CTAC team who were part of a primary care access programme. They were our pilot test to see whether or not this approach and this methodology would work for the CTAC teams. So excuse me, just need to make my screen a little bit bigger so I can read these. So first example here, this was our general practice team. So the challenge that they had was about 34% of their patients unable to access routine appointments, which resulted in around about 57% of patients being asked to call back as the routine appointments were all gone, and they needed to call back to be able to book one. They did some data collection to get those numbers and to understand exactly what was going on and to generate their change idea, which was to amend up to 5 of their urgent on-the-day appointments to routine appointments. So this gave them a little bit more flex in the system of them being able to offer those on a temporary basis at 24 hours or 48 hours or 72 hours until they could build them into their longer term structure and an appointment book for the future going forward. So the outcome ultimately of those tests and making those changes is that they then had 61% of patients able to access their routine appointments, which is an increase from where they started. And there was a huge reduction in the number of patients that were being asked to call back. So obviously that makes things happier from a patient point of view, and it also means fewer phone calls being manned by the staff on the reception desk. So good outcome for everybody there, and something that they could continue to work on to see where they could begin to look at increasing the percentage of appointments or potentially changing other appointments to meet that need. The next example we've got is our CTAC service. So their challenge was being able to understand the demand data for CTAC services in their area. And what they wanted to look at was establishing if and how much of what CTAC services should be covering in their area was still being delivered by general practice. The change idea that they came up with to be able to get this data and understand the demand data was developing an MS Forms questionnaire, which they would share with a few GP practices as a test to be able to capture the general practice demand and activity data that actually fell into the remit of their CTAC service specification. The outcome of this change idea and this test was that we learned that there was variation across the practice's ability to be able to capture this data and to be able to share data around demand for the CTAC services. And it also highlighted that there was generally a time-consuming manual data collection process needed in general practice to access this data, which gave them food for thought about how they might go forward to be able to develop that understanding in the future. Our third example here is a primary care example. So their challenge was they had around 50 to 60 acute prescription requests per day, and what they noticed from that is a significant percentage of those were for antidepressants. Having looked at their data and generated their potential change ideas, they selected this one, which was the introduction of a standard operating procedure for antidepressants to support the team in the practice to move appropriate patients onto repeat prescriptions, which ultimately led to the outcome of a reduction in the average acute prescription requests per day and a reduction in the demand for antidepressant acute prescriptions. Again, something they would have been to continue to work on to increase those numbers of reducing the demand. We've got lots of other examples of what's happened in the PCAP programme, which can be viewed through the links that we have got here around our primary care access programme and then learning from the teams. So you can access these when we share the presentation later on. So I'm now going to hand you over to my colleague, Mary.
Hi everyone, so my name is Mary Loughran and I'm an implementation and improvement facilitator in the primary care team, and I'll also be supporting the work of the teams in the Primary Care Improvement Collaborative. So the collaborative is open to any primary care team interested in using quality improvement to improve an aspect of their service, including GP practices, GP clusters, pharmacotherapy teams, CTAC teams and multidisciplinary teams within primary care. So the collaborative is not open to NHS borders. Teams within Edinburgh City HSCP that are part of the demonstrator site, and I know Alison's just popped the information on that in the chat. It's not open to NHS Ayrshire and Arran or NHS Shetland teams who, as we've already said, are part of the demonstrator site work. You will be required to complete an MOU, and you will be required to identify a contact person for your team that HIS can collaborate with to make sure you're ready at the start of the collaborative launch. So once you have joined the collaborative and decided that you would like to join an improvement sprint, to make sure that you're ready to participate in one of the 4 or 8 week sprints, you must be able to identify an improvement team. This will include a decision maker, team lead, administrative support and a key partner. And for an example you can see there is, for example, CTAC or pharmacotherapy teams may want to consult with a general practice just to make sure that they're on board with any improvement plans that you've got or any work you want to undertake. You must be able to commit to 2 to 4 hours per week over the period of the 4 or 8 week sprint. And this will just be a mixture of sessions with Healthcare Improvement Scotland, and it will also be time to work on your own project within your own team. So in terms of what teams will need to do, once you have joined the collaborative and received your welcome email, you will be expected to attend an introductory call with one of our improvement team. Somebody in our team will be in touch to set this up with you. As Alison had shown earlier on, there's quite a lot planned for the rest of this year, and what would be really helpful for us if you could indicate which activities that you're wanting to participate in, taking into account what your interests are and what your capacity is. And then once you've been accepted onto one of those sprints, or you have chosen which activities you want to participate in, to get the most out of it, we really do ask that you actively participate in those activities. Once you've been confirmed as taking part in a sprint, again, you will have an introductory call that will be set up with a member of our team, with one of our improvement team. You will be expected to participate in weekly coaching sessions with your identified coach. You will need to identify and test a change idea. You will need to collect data and provide us with progress updates as the sprint progresses. You will need to attend a next step session and understand how to actually implement and spread that change. And maybe most importantly, what we would really love is if you could share your learning locally, if you can share your learning as part of the collaborative and with the wider demonstrator site teams, again through those sessions that Alison had given an overview of earlier on. If you do have any questions in relation to this, please just pop them in the chat, because I'm going to hand you back to Claire now, who will take you through some questions and answers that have already been submitted.
Thanks, Mary. So I'll start off with some of our questions that were sent in with the registration form for the info session. I won't read out the name of the person who submitted the question, but we'll just get a quick check about whether or not your question has been answered. So first question that came through was, what level of support to teams and services received from the team? I'm assuming that's asking what are his going to do to support the teams and services that are coming through to be part of the collaborative. So for the person that asked that question, I'm hoping that what we've covered in the session so far has answered that for you. If it hasn't, please feel free to pop something in the chat or to contact the team directly, and we can have that discussion with you to be able to reassure you about what the collaborative offers, what you'll get out of it, and how we're able to help. Another question came through asking about an indication of size, perhaps number of practices or population and skill mix. This is around what sort of level should be applying for the collaborative. So does a whole HSCP apply for the collaborative? Do individual teams apply for it? Do localities? Again, it probably is what fits right for your context. I think our view is the more the merrier. So if you've got an HSCP where you've got teams that want to work on access, you've got teams that want to work on pharmacotherapy, and you've got CTAC teams all in there, then absolutely, if each of those teams individually wants to put an application through to the collaborative, it would allow you to work at different paces and different levels. So hopefully that will answer that question. And then the second part of that was around skill mix. So again, it would depend on your team and your sort of topic area or your area of focus, but probably sensible to think about who have you got that's in an influential in a decision-making situation that can agree to these small tests of change being put in place. Who have you got that might have some QI skills that you can use already, or who have you got that wants to build those QI skills that can get those things from the collaborative, from the sessions that we're going to offer. So there is no ideal size or makeup of team. Again, if you're not sure and you've got any questions, contact the team and we can have one-to-one conversations with you about who you think you might want to involve. And also, things can adapt and change as we move on the collaboratives over a period of time. Staff may well move and do different things. So just because you've put some names on an application form at the beginning does not mean that it can only be those people all the way through the collaborative. Another question asking, what does the training involve and can it be tailored to a specific project being undertaken in a role? I'm not sure specifically what that question means, but hopefully what we've described so far has given an overview of what's available in the collaborative. If it's somebody who might be thinking about trying to do an individual QI project and maybe undertaking something for a CIFS level of training or a skill level of training, I would say probably the collaborative is not suitable for that, because we would definitely be looking at teams working together collectively to be able to make changes together. So it's not necessarily for an individual doing a QI project, but definitely more a team working together. But if somebody's in a leadership role and wants to come into some of our QI sessions, then absolutely that's appropriate for them to top up their skill set. There was a question came through about some South East Edinburgh teams being successful in their bid. So I think a separate conversation about who's in a demo site and who's not and who's available to apply for the collaborative can be a separate conversation that we can pick up. So that covers all of our submitted questions coming through. Let me have a look at the chat and see what we've got. So Anna, I answered your question around, in the example we described an improvement to routine appointments and what was the impact on urgent. Our data collection process with that team identified that there was unused urgent appointments. So those were the ones that were selected to be converted to pre-bookable routine and tested. Let me keep scrolling down. We'll pick up the conversations about who's eligible in what areas through separate individual conversations. I don't see any other questions coming through in the chat. Have I missed anything? Nope. Does anybody have any questions that they want to ask? Feel free to pop your hand up and we can come to you, or pop them in the chat, or you'll get an opportunity through our post-session questionnaire to be able to pick anything up that hasn't occurred to you in the moment. And as Alison said, we'll develop that response to all of the frequently asked questions and share that with everybody. We will be sharing the slides as well, Gail, and the recording will be posted on our website and will be available, as Alison said at the beginning, for anybody who's missed it or anybody who wants to go back and listen to our wonderful voices again and hear all about the collaborative. So I think I've mentioned that we are going to be sharing a survey with you afterwards. It's just to check in about whether what we've covered in the session today is enough, whether it gives you the information that you need, whether or not we might need to develop another one of these or some other resources to be able to answer any questions or alleviate any concerns that people might have around being involved in the collaborative. Brian, we will have more than one care navigation or workflow optimization sprint option, and the links through to our primary care access learning, and there could be a brief insight around one, or there could be other information available. So have a look at the website and we'll pick one up there. I cannot think of one right off the top of my head, but I know that we will have one. So moving on, the next thing is exactly that, is having a look at joining the Primary Care Collaborative. The link is there through for the information page and the application form, and also we have a link for contacting us. Now, let me check, is there any questions that have come in at the last minute? No. So wonderful. Christopher has popped through the links for things there. So unless there is anything else that we need to say, the key date of the 16th of February is when the initial applications process is going to close, and then we will be in touch after that date to move forward onto the next stage of the collaborative. Anything else we need to cover, Alison?
Don't think so, and that's us just about on time. So thank you everyone for joining us. The information's there about how to apply. Any questions, just get in touch, and thank you, and do pass on the recording once it comes around to anyone who you think would be interested.